We now turn our attention to the primary purpose of ordering an echocardiogram, and that is to get an interpretation. In this case, we have 9 images to look at. And here, the first one is a parasternal long axis. Another view of the aorta and parasternal long axis. We still do M mode, not for measurements, but for looking at subtle wall motion changes in the valves and the walls. Now we have some color Doppler, spectral Doppler, more 2D in a short axis, 4-chamber, more color. And now we're back, and we are asked to make interpretation from those 9 images. We frequently start off with an introduction giving some clinical information as to why the echocardiogram was ordered. In this case, it's 25-year-old male with a heart murmur. The next slide gives us some information as to what is expected, that is to make the interpretation. They may give you some refresher information with regard to controlling the images. But it says to get the control for the imaging for the diagnostic tree is to just click on Add. Now, obviously, these images are all digital because we're going to be searching. We don't permit free typing because you can't search on free typing. So we make it as easy as possible to find the appropriate diagnostic comment so that we can all be judged. The tree can be opened up as almost all trees, or it can be searched. For example, here we have an eccentrically closing aortic valve, and we see that both in 2D, and we also see it in M mode. And then when we look at the short axis, we see the criteria for a bicuspid valve with a fused commissure and 2 mobile leaflets. So we have pretty good evidence that there's a bicuspid aortic valve. To enter that, we could do several things. One, we could indicate by opening up aorta, aortic valve, and looking at the structure, and there is bicuspid aortic valve. Or we can also do the same thing by just, if you didn't happen to know where to find it, you can then just say bicuspid. Just BICU is close enough, and hit search. And there it is, bicuspid aortic valve, and we just double click. And there it is on there. Well, we also found that the patient has mild aortic regurgitation. We see it there in the 4-chamber view. We see it also in the long axis view, and we see it in spectral Doppler. So we then can do the same thing, only this time we'll go ahead and open up the tree. We'll look for aortic regurgitation, and it's mild. Now, the other thing that we noticed in this recording was that the aorta looked kind of funny. Even the sonographer noticed it. They made an effort to get the distal portion of the aorta. And the more distal, or the tubular, or the proximal ascending aorta looks wide. Let's find out if it really is. We'll just do a measurement. And what we want to do to highlight is the fact that this is all, it's already calibrated, and you do that when you enter the images. You look at above, you see controls. There's linear measurement and area measurement, ejection fraction, aortic valve area. So here, let's just make a linear measurement. and 3.9, which clearly is abnormal. If I say, well, maybe I got it wrong, let me try it again. So we'll just try it one more time to see if I really went from, and that's actually a little over 4, but so it is dilated. That's clearly about our, now we can also make the measurement leading edge to leading edge if you want. We'll talk about that in a second. So what we have now is mild aortic regurgitation, mild aorta, mildly dilating the proximal aorta. I got to get it right here. So we go back to the tree, and actually we might even say aortic dilatation. Let's see what find, or dilated aorta. Let's put it that way and see what will happen. There she is, just a mild proximal aorta. That's exactly what we want. Okay, so that's the essence of the exam. We could go through, there's a lot of normal information, but I won't take the time to put it in, but basically that's the pathology that needs to be in this report. So we submit that, and we will then go, and there it is. There's what I said. Here's the 3 major pathologic comments, and that's exactly what's here in the Crete editors. The rest of it's all normal. So we then move along. Now in this case, we now get the teaching component and just pointing out what we've actually done, the components of why this is a bicuspid valve. You see the eccentric closure here in these 2 views. We can also see some curved doming of the valve in the upper view, upper image. And then we see the criteria of the fused commissure, and then the 2 leaflets, which are still mobile, all of the classical criteria for a bicuspid valve. And we then show the dilated aorta, and we show you the 2 different measurements. The ASC guidelines say you should do leading edge to leading edge. We have always done inner edge to inner edge, and many laboratories do use inner edge to inner edge. That's still a point of controversy. Now we go on, you can ask questions as well. And the question here was, what additional views should have been done that wasn't done? And why would you get this additional view? And the answer is you should have done a suprasternal view. And why? Because bicuspid valve is frequently associated with a coarctation, and you wanted to look for a coarctation. Now, you can then see your answer against the answer of the creator side by side, just as we did with the measurements.